Dr. Amber, and today we're tackling some topics the NCLEX loves to test on: acute kidney injury and chronic kidney disease. Acute kidney injury, or AKI, is a sudden loss of kidney function that is often reversible if treated before permanent kidney damage occurs. Causes depend on where the problem starts. Prerenal is caused by decreased perfusion to the kidneys. Think dehydration. Intrarenal is caused by direct kidney damage. Think nephrotoxic drugs like CT contrast. And postrenal is caused when there is a blockage of urine flow, causing urine to back up and damage the kidneys, like BPH. So what findings will we see with AKI? Well, the kidneys aren't working, so they cannot regulate fluid and electrolytes. So we're going to see a lot of imbalances. In the earlier phases, the client will stop clearing any urine at all. We will see a rising BUN and creatinine, fluid retention and overload, and lots of potassium and hydrogen ions building up. This causes hyperkalemia and metabolic acidosis. Later, clients will typically urinate large amounts, and we will see dehydration and hypocalcemia. So, when we're worried about our fluid and electrolyte imbalances, we must monitor the BUN, creatinine, and urine output to track kidney function. We must monitor electrolytes, especially potassium and sodium, to identify any imbalances early. And monitoring daily weights give us an accurate picture of fluid status. And here's an important NCLEX tip. Clients with AKI must be kept on a continuous cardiac monitor due to the risk of dysrhythmias. So, do you remember which ECG changes you will see with potassium imbalances? Well, although there are many, the one the NCLEX really wants you to know is how potassium affects the T waves. Hyperkalemia causes peaked T waves, so the T wave will go up as the potassium level does. With hypokalemia, we will see flat or inverted T waves, so the T wave goes down as the potassium drops. So remember, hyperkalemia can cause life-threatening dysrhythmias, so we must treat it. We can remove it, shift it, or dialyze it. So there are some medications we can give to decrease it. Polystyrene sulfonate, or Kayexalate, binds potassium in the gut for stool excretion. We can also administer potassium-wasting diuretics, specifically loop diuretics like furosemide, to flush out potassium through urine. IV insulin with dextrose can be given to temporarily shift potassium from the bloodstream and hide it into the cells. And if hyperkalemia is severe or unresponsive, anticipate dialysis. So now it's time for our first NCLEX quick check. So pause to answer the questions. Now let's review. What ECG changes occur with hyperkalemia? We'll see peaked T waves. Remember, those T waves go up as the potassium level does. And what treatment should the nurse anticipate for hyperkalemia? Well, there is polystyrene sulfonate, or Kayexalate, to remove potassium through the stool, IV insulin with dextrose to shift the potassium into the cells temporarily, and finally, dialysis may be needed. So in addition to interventions focused on fluid and electrolyte imbalances, we must prevent further renal damage and infections. To prevent permanent renal damage, we should protect the kidneys by avoiding nephrotoxic medications like IV contrast or vancomycin. And we should limit protein intake to decrease the kidney's workload from protein waste. And if kidney function continues to decline, dialysis may be needed. And remember, infection prevention is key because uremia suppresses immunity. We must provide frequent skin and oral care to prevent infection. And we should monitor for signs of infection like a low-grade fever and tachycardia. Now, let's talk about CKD, which is a progressive and irreversible loss of kidney function. And unlike AKI, which can improve, CKD worsens over time and is staged by the GFR measurements. CKD is typically caused by anything that damages the small vessels like diabetes or hypertension, or things that damage the kidneys themselves like polycystic kidney disease or acute kidney injury. So CKD affects almost every system due to fluid and electrolyte retention. First, urine output drops, leading to fluid overload. Next, the kidneys can't excrete electrolytes or acids, so they build up. So we will see elevated electrolyte levels and metabolic acidosis. The kidneys also lose their ability to activate vitamin D, so calcium levels drop, leading to hypocalcemia and bone disease. Decreased erythropoietin production means fewer red blood cells, so clients will develop anemia. And finally, urea builds up, causing waste to enter the bloodstream. So we will see uremic symptoms like nausea, vomiting, and itching. So remember, due to retention of fluid and electrolytes, everything will be high, except for hypocalcemia. Many CKD interventions mirror AKI because it is all about fluid and electrolyte balance. We must continue to monitor fluid balance, electrolytes, and kidney function. And do you remember the priority intervention if the client's potassium is high? We must implement cardiac monitoring to assess for life-threatening dysrhythmias. And we'll still treat that hyperkalemia with Kayexalate or loop diuretics. And finally, we must teach clients to avoid over-the-counter medications that contain electrolytes. For example, magnesium and milk of magnesia. To maintain adequate fluid balance, we must monitor that client closely. We should weigh them daily at the same time on the same scale because small fluctuations can indicate big fluid shifts. We should also monitor for signs of overload like edema and crackles and teach clients to report sudden weight gain. And in the late stages of CKD or with clients on dialysis, we should restrict fluids and avoid large volumes of IV fluids. Finally, we must administer diuretics as prescribed. CKD increases cardiovascular risk from arterial stiffness and hypertension. To prevent this, we should closely monitor the client's blood pressure and give antihypertensives as prescribed. And we should limit sodium to reduce the workload of the heart. Other dietary modifications include implementing a low-protein diet to reduce the kidney workload. But here's an NCLEX twist. Clients on peritoneal dialysis actually need more protein to replace albumin lost through the peritoneal dialysis fluid. And finally, clients should avoid foods high in electrolytes. For example, potassium in salt substitutes, sodium in canned goods and deli meats, and phosphorus in meat, eggs, and dairy. So remember, CKD increases the risk of bone disease and anemia. So to manage bone disease, we must give phosphate binders to decrease phosphorus levels. The kidneys cannot excrete phosphate, causing calcium levels to drop. We should also administer calcium and vitamin D supplements to support bone health. And to manage anemia, we must closely monitor the H&H and administer erythropoietin injections, iron supplements, or even blood transfusions. So now it's time for our next NCLEX quick check. So pause to answer the questions. What findings indicate fluid volume overload in clients with AKI or CKD? Sudden weight gain, crackles, and edema. What should you teach clients with CKD about protein intake? Clients should follow a low-protein diet unless they are on peritoneal dialysis because protein is lost through the peritoneal dialysis fluid. So if diet and medications are not enough, we move on to dialysis or kidney transplant. Dialysis removes waste products and excess fluid from the blood when the kidneys stop working. So it acts as an artificial kidney to manage the condition. But remember, it does not cure the disease. So there are multiple types of dialysis. These include hemodialysis, peritoneal dialysis, and CRRT. Hemodialysis requires an AV fistula or graft that lets blood flow to and from the dialysis machine, and appropriate nursing care is key to protect it. We must assess the patency by feeling for the thrill or vibration and listening for the bruit or whooshing sound. We should check pulses and capillary refill distal to the site. And remember for NCLEX, we should never take a blood pressure or perform venipuncture in the affected arm because we can damage the graft site. So hemodialysis comes with complications we must monitor for. First is hypotension or disequilibrium syndrome, which occurs when fluid shifts too rapidly. So if we see a drop in blood pressure or a sudden change in mental status, we must slow the dialysis rate. Next is air embolism, which is caused by air entering the dialysis tubing. We should monitor the client closely for signs, including dyspnea, chest pain, or confusion. And finally, heparin is used to keep the filter from clotting, so closely monitor the client for signs of bleeding. Next is peritoneal dialysis. This is when dialysate fluid is infused into the abdomen, where it absorbs waste through the peritoneal membrane and it's then drained. Nursing care focuses on infection prevention and comfort, so we should warm the dialysate fluid before infusing it because cold fluid can cause cramping. We must use sterile technique to prevent infection. Signs of peritonitis include cloudy peritoneal fluid and fever. Finally, clients need a high-protein diet because protein is lost through the dialysate fluid. Now it's time for our last NCLEX quick check. Let's pause to answer these questions. How is patency assessed in an AV fistula or graft? We should feel for a thrill or vibration and listen for a bruit or whooshing. These findings tell you that blood is still flowing like it should be through that graft. What procedures should be avoided in the arm with a fistula or a graft? Blood pressure measurement and venipuncture, like a VAD insertion and blood draws, because these can cause graft damage and failure. And finally, what complications should the nurse monitor for when performing peritoneal dialysis? We must closely monitor for infection, so assess for cloudy peritoneal fluid, which indicates peritonitis. So now you are ready for questions on AKI and CKD when taking the NCLEX.